I'd like to thank Coriell for inviting me. Basically, I was going to try to do a quick overview of pancreatic cancer. I've seen a lot of pancreatic cancer over the many years I've been here at Cooper. Basically, I'll try to quickly go over epidemiology, risk factors, symptoms, some basic anatomy of the area, and how we go about treating and managing pancreatic cancer without getting bogged down in too many details, because as you can guess, it's a long topic. So pancreatic cancer incidence and epidemiology, this is based on statistics from the American Cancer Society, which you can find on their website, but basically in 2014 in the United States, they expect about 46,000 pancreatic cancer cases, pretty evenly split between men and women, 23,000 apiece. It is the fourth leading cause of cancer death in the United States. About 80% of the pancreatic cancer cases occur between age 60 and 80, and less than 2% of cases occur in patients younger than 40 years. This again is from the American Cancer Society statistics, and it just shows the breakdown of the top 10 cancers in men and women for 2014. And you can see here pancreatic cancer isn't even on the top 10 list for men. It's down at number 11, accounting roughly for about 3% of all cancers in men. In women, it comes in at number 9. And this is just cases of pancreatic cancer occurring. And this is for 2014. And you can see that the leader here in women by far is breast, and lung cancers, colon cancers are very common. In men, the most common cancer is prostate. But pancreatic cancer is way down on the list. Now, if you look at these statistics, this basically shows cancer deaths. So these are not people just getting cancer, but actually dying of cancer. And you can see pancreatic cancer is number 4 on the list for both men and women. And overall, when you combine men and women, it is the number 4 cause of cancer death in the United States. And that's because it's a particularly deadly cancer. A lot of the other cancers, although they may be occurring more frequently, they have better cure rates with the current management that we have. This just lists some of the risk factors for pancreatic cancer. We're still okay? And as common with many cancers, you can see that cigarettes are on the list. And basically, cigarette smoking increases cancer risk roughly about 2.2 times. Again, I got this from American Cancer Society statistics. The other important thing about cigarette and cancer risk is that if you stop smoking, the pancreatic cancer risk gradually diminishes, and after about 15 years of stopping smoking, your cancer risk is pretty close to what it would be in the normal population if you hadn't smoked at all. Patients with type 2 diabetes for more than 10 years, roughly about 1.5 times increased risk. Obesity, and this is really very obese patients when you're talking BMI over 35. When you see common obesity statistics, obesity is defined as a body mass index greater than 30. So these are patients even bigger than that. But these very big patients, their cancer risk is also roughly about 1.5 times of the normal population. Heavy alcohol intake, meaning more than 6 drinks a day, close to 1.5 times increased risk. And patients with chronic pancreatitis, which is a chronic inflammation state of the pancreas. It occurs most commonly in patients who are heavy drinkers, but patients who have an actual diagnosis of chronic pancreatitis, their pancreatic cancer risk is roughly about 2.7 times what it would be in a normal population. There are also hereditary factors, which I can't say know a whole lot about, but we have somebody else here who's going to talk about that. You'll hear Tara here in about half an hour. And this just shows some basic anatomy of the area. This bigger picture over here basically shows how the cancer is sort of tucked behind the stomach. And you can see the stomach here. This is the end of the stomach, and this is the first part of the intestine here. We call it the duodenum. And then you get to the rest of the intestine here, the jejunum. You can see basically the duodenum is wrapped around this part of the pancreas here. And just for convenience, we apply these terms to various parts of the pancreas. We have a head, there's a body and tail, and there's a narrow band between the head and the body that we call the neck. And you'll see on CAT scans, and when we're looking at it surgically in the operating room, you can pretty clearly see head, body, and tail, and it's very easy to communicate exactly what you're talking about when you're talking to other people. The other thing you see in this diagram here, I keep losing the arrow, but this is the liver over here, and these are bile ducts coming out of the liver that carry the bile. Bile is made by the liver. It's another substance that helps digest the food, and the bile comes down through these ducts and comes down to this first part of the intestine, and when it gets to the intestine, it helps digest the food. You can see the gallbladder sort of is an appendage coming off the side of the bile ducts. Also coming in the same place in the duodenum is this duct here, which is the duct of the pancreas, and that basically carries the pancreatic enzymes. And all these things get into the intestines, and they basically help digest the food. But it tends to be an important point, because when you get pancreatic cancers or other types of tumors, if it occurs in the head of the pancreas, it can cause a blockage of either of these ducts, or more typically both of the ducts. And if it gets to be a big enough tumor, it will actually cause a blockage of this part of the intestine, the duodenum. And each one of these things has distinct symptoms that it will cause in the patient. Now, over here, this is like a little more detailed picture of the pancreas. And again, we see the head, neck, body, and tail. And then you also see this little part here, the uncinate process. You don't see the uncinate process on this particular diagram, but the uncinate process is a part of the head that actually curls around in back of the pancreas. And the significance is that in this area behind the neck, but in front of the uncinate process, there's some significant blood vessels that run down in this direction. And basically, these are the main blood vessels that run to and from the intestines. Basically, all the blood that goes to and from your intestines runs through this area. And it tends to be very problematic when you're dealing with pancreatic tumors, because when the tumor gets big enough, it gets into these blood vessels, and that's often a limiting factor in terms of trying to manage these patients. I keep losing the arrow. Oh, there it is. Sorry about that. This little box here, just a little review of the functions of the pancreas. It's a gland that actually has two types of function, what we call an endocrine function, which means that it can make various hormones. The most commonly known one of those hormones is insulin. And these hormones go into the blood system and they have effects. Insulin is very important in terms of blood sugar control. It also has what we call an exocrine function, where it makes enzymes. And these enzymes are made by the pancreatic cells, and they go into this duct, and they travel down to the intestine. As I mentioned before, they help digest the food. So two very important functions of the pancreas. This is just a list of some of the symptoms and signs that patients will present with when they come in with pancreatic cancer. And I sort of divided it up into cancers of the pancreatic head and cancers that involve the body and tail. Now, if you look at this body and tail list over here, you can see common ways, symptoms that patients present with. You see weight loss, pain, nausea, weakness, vomiting, anorexia, meaning that the patient's not hungry, doesn't want to eat. And you can see the percentages of patients that come in with these symptoms. But if you think about it, these are a lot of sort of vague symptoms. I mean, I've had every one of these. I'm sure most people have had every one of these symptoms at one time. But usually you don't think too much about it unless it happens for a prolonged period of time. But because it's so vague, it's really non-specific. This is how pancreatic cancers can so easily sneak up on people. They can get to very large sizes before they're discovered, and often they've spread. The pancreas sits sort of in the back of the abdomen, and so you don't really find the cancers very early. And so you get a lot of vague symptoms while the cancer is growing for a long period of time. Now, if you look at the pancreatic head cancers, you'll see some of these vague symptoms like the weight loss, the pain, the anorexia. But there's also some more specific symptoms, like they get jaundice, they get dark urine, they get light stools. And basically, you see those things. How do I make this thing go back? But just to sort of show you, if a cancer occurs here in the pancreatic head, we mentioned how it can cause the blockage to occur in these bile ducts or the pancreatic duct. Well, if you get a blockage in the bile duct, the bile will back up, and basically backs up into the liver, and it's in the bloodstream, and that's basically where the jaundice comes from. All the bile in your body makes your skin look yellow. It also requires the body to get rid of the bile through the urine, so your urine basically becomes very dark. It'll become like a tea color. The other thing is that if the bile is not getting through the duct into the intestine, your bowel movements will become very light in color. In fact, they'll be white, like white or an off-white color. The brown color in a normal bowel movement is very dependent on the bile getting through. So that's how the patients can come up with these symptoms. Basically, it's a symptom of bile duct blockage. Now, how do we go about imaging it? Nowadays, we have all sorts of fancy tools for trying to look at the pancreas. Not everybody's going to come in with a nice little cartoon picture like I was showing you before. The tools that we commonly use, probably the first test that's done is what they call a transcutaneous ultrasound, or people just call it an ultrasound. This is just like a regular ultrasound that you would get if they were looking at your gallbladder. Women get it if they're having an evaluation of their uterus or ovaries, or when you're looking at a baby, they sort of grease up your skin and they put the ultrasound probe on you, and they take a look at your insides, and it gives pretty good images. It's nice, minimally invasive type of test, and you can get a lot of information from that. But that's usually not enough information on which to go about fully diagnosing a pancreatic cancer. But it will also diagnose other things. For example, another common type of problem that will cause bile duct blockage is gallstones. Gallstones can get out of the gallbladder. They can cause pain in the gallbladder. When they get out of the gallbladder, they can cause blockage in the bile duct, and you can often see the gallstones too. And so just because you have jaundice doesn't mean you're going to have pancreatic cancer. Usually the most common reason you have jaundice is from gallstone disease. A very nice image nowadays is a CT scan, or people call it a CAT scan, and I'll show you some images of that in a minute. MRI, MRCP is similar to CAT scans. I'm not going to go through all the details of everything on these slides because I'm trying to save some time here, because we have to get through this quickly. But MRI, MRCP will give you pictures somewhat similar to what you see with a CAT scan, although it's somewhat different type of imaging technique that's utilized. ERCP basically stands for endoscopic retrograde cholangiopancreatography. I'll show you some images of that too. Basically, it looks at the bile duct, that's what this word cholangio means, and also looks at the pancreatic duct, that's what pancreatography means. And basically it's similar to other endoscopic techniques like upper endoscopy or colonoscopy. Basically a GI doctor, a gastroenterologist, putting a scope down the patient, and you can actually get into the bile ducts where they enter into the duodenum, like I was showing you on the other diagram. Endoscopic ultrasound is another type of imaging technique that we have, which is somewhat similar to the transcutaneous ultrasound that we do through the abdominal wall. However, this is done endoscopically. Basically, it's also the GI person putting a scope down the patient, except this scope doesn't have an optical view. It gives you an ultrasound view. And they can actually get down very close to the pancreas. If you think on those images I was showing you before, I don't want to try to go in reverse again, but you can get down into that duodenum, and you're basically within millimeters of the pancreas, and you get very sharp images with that, so it's a very useful technique. And here basically just sort of a review of the anatomy again, but basically when they do the ERCP, they come down through the esophagus, down through the stomach, and you can actually get down to the duodenum here, and the GI doctor can get into these ducts, and we can get pictures of it. So it's a pretty fancy technique, although not all GI doctors will do it. Usually you need somebody who specializes in that technique.
Is it painful?
Well, it's like other endoscopic procedures. Somebody asked if it was painful. I don't know if everybody heard that out there. But basically it's like other endoscopic procedures like upper endoscopy or colonoscopy. You have to be sedated. Usually they'll do what they call that twilight sort of anesthesia. I mean, you have to be out for it, because they're shoving a big tube down your throat. But again, I'll show some images of that. And I'll show some images of a CAT scan too. Here, this is a type of x-ray you would get from an ERCP. And you can see this is a patient laying here. It's like basically an x-ray. You can see like there's ribs. You can see some of the spine there. This is the actual scope that's going down the patient's throat, and it gets down into the duodenum. Some of these dark areas, that's just gas in the intestines. But I'm not sure how good this projects that everybody will be able to see it, but here you're actually seeing the pancreatic duct. And this duct is very dilated. They basically shoot contrast into it. You can see how it's like sort of has a bigger size. It should be very narrow. And basically, actually you can see here they have a wire that the endoscopist would have shoved into the duct. Basically it's like a guide that they use to help them put the catheter in, and then they inject the dye. But this patient has a blockage right here in this area. Like this is part of a duct here, and then you sort of lose it. So this blockage is basically due to a tumor. So you're seeing the effects of the blockage when you do this test. And the other thing that the GI doctor can do, once they're in there, they can do a biopsy. They actually have, again, it's like a little, one of these wire type of things that they put in there, and it has these tiny little brushes on the end, sort of like brushes you would use to clean a test tube, except it's really tiny, and they can actually jam it through there, and you get tiny little bits of cells that they collect that way, and you send it off to pathologists, and that's a relatively simple way and very effective way to get a biopsy of whatever's causing the blockage there in that duct. Actually, I will sort of try to go back for a minute, but yeah, this is where that scope is. I mean, basically, they got that wire in there, and then the area I was showing you that was all dilated was this part of the pancreas there, and that patient had a blockage somewhere in this area. Now, it doesn't line up exactly like the diagram, but basically that's what you're looking at. And this duct is not normal. It's very dilated, but that's one of those things that happens when you have a blockage in a duct. The duct that's further upstream will dilate, sort of like when you put a dam on a river and the river backs up, it gradually starts turning into a lake, and that's the effect that you're seeing here. So that's ERCP images. This is another ERCP image, except this one is looking at the bile duct. This is a very dilated bile duct here, and this is like it has the right and left parts going up into the liver. These are all the smaller bile ducts going up into the liver. It's all filled with contrast. This area here is some intestine that's filled with some contrast. And then what you're seeing here, this is actually a normal bile duct right there. And you can see it looks normal up to here, and then there's a blockage here, and you can see this part of the bile duct is all dilated. And so this patient basically has something causing a blockage there. And again, the endoscopist can actually get a biopsy of this area, and you'll have some idea, hopefully, of what you're dealing with. Now, in this particular image, as opposed to the one that we saw before, you don't see the scope anymore. They removed the scope from the patient, but you can see the contrast is still sitting in the duct, like it hasn't emptied. This is a CAT scan image. Now, this particular image is sort of like slicing a patient in half, just like a magician would slice a woman in half, except they don't really do it. Like this is like an X-ray slice through a patient, and what you're seeing here. Now, don't worry, I'm not going to quiz people on this. At least I hadn't planned to, but you can see they cut through the patient. You can see here's cross sections of ribs around the edge. This is the spine back here. This is a right kidney. This is the left kidney. Now, this patient did receive contrast, like they get what they call IV contrast. Basically they start an IV on you and they inject contrast, and they also have what they call oral contrast. You swallow a bunch of stuff. The IV contrast goes into the blood vessels, and you can see here, this is the aorta. The IV contrast makes all the blood vessels look more white, and so this is the aorta. This is a vein from the left kidney. This is a vein from the right kidney. This is what they call the portal vein, which carries all the blood from the intestines to the liver. You can see that there. This here is the pancreas. This is like what we would call the body and tail area of the pancreas. I was mentioning before on that other diagram, when I was telling you about the uncinate process and how the blood vessels run right in front of the uncinate process. You don't really see the uncinate process on this image, but you do see where the blood vessels are. These are the blood vessels that go to the intestine. Here's one here, here's another one there. I mean, you see both of them right there. And so this basically would be the neck area of the pancreas that you're seeing. Now, we would have to click down when we're looking at a CAT scan, because a CAT scan is usually like about 100 images. Each image is like about a 1/4 inch slice down or up from this. And so you end up with like 100 slices through the patient with the x-ray. And you sort of have to create a three-dimensional image in your mind as you're going through it. But we'd have to go down through a couple other slices to see the pancreatic head. And basically it would be sitting in front of this portal vein here. Over here, this is basically intestines with some of the oral contrast that the patient swallows. Usually they have the patient start swallowing the contrast roughly about 2 hours before. And to get an ideal CAT scan, you want to fill the intestines with contrast as much as possible, because it just shows you where all the intestines are. Because you're looking for anything that could indicate spread of cancer too. You're not just looking for a tumor. Now the next picture I'm going to show you is going to be an abnormal one. And you can see here, it's sort of similar slice through the patient. You can see liver here. This is part of the right kidney, left kidney. Here's a spine. Here's an aorta. Here's like a blood vessel behind the pancreas. Here's that portal vein. But you can see this portal vein is very deformed. And this is a very obvious big old mass in this patient here. And this is actually in the pancreatic head area. This would be like the neck part of the pancreas. This would be the body and tail. And you can actually see this little thin darker gray shadow here. That's actually some of the pancreatic duct that you're seeing. So you can see a fair amount of detail. Now, the other thing is I'm showing you like a picture that's going to project well, where everything is really nice. It's not always such a nice picture and so obvious like in this particular case. In fact, this tumor in this patient ended up being benign. This was not a cancerous tumor because it was fairly large. If this was like a regular pancreatic cancer, generally when they get this big, they've already spread everywhere. And so usually when you see a really big thing like this, it tends to be benign or something that's like nearly benign. But you can just see that it has a very sharp contrast to the other tissues. But you can also see cancers that have a color, or I should say a shade of gray, very similar to the normal pancreas. And so it's not always so obvious. And that's why although CAT scan is a great imaging modality, it's by no means a perfect imaging modality to see these things. And the next image, this is because of the power of the modern computers we use to do CAT scans. It will let us reconstruct the X-ray information in what we call a coronal reconstruction. So this is sort of like looking at a patient, from standing in front of them, and you're looking at them, but you're doing a slice, running from their head down to their feet. And so it's like sort of slicing open the top part of their body and removing it. Now you're looking at or I should say you're slicing off the front part of the body and you're looking at the back part of the body. And again, this is the same patient we saw in the last CAT scan, but here's this mass. Here's the portal vein, very deformed. You can see the thin outline of this white vein with the contrast in it. Here's the liver. You can see how it sort of looks similar to those other cartoon images that I was showing you. I keep losing this arrow in here. That's why I have to keep waving it around. Hopefully it doesn't confuse people too much. But see, it disappears. Stay there, arrow. And then you have to like move it around to get it to show up again. But anyway, this is actually the part of the stomach you're seeing here with contrast. This is the tumor in the pancreas. You don't really see much of the contrast in the duodenum, but this shade right here, you're actually seeing some of the duodenum here, right there. This going around the mass here. And this is just more intestines. Like you can see some of the colon here with contrast in it. So it's pretty nice images. But again, it doesn't always show up this nice. So a couple words about role of biopsy in pancreatic cancer. As a general rule, you like to have a biopsy to see exactly what you're dealing with. And what we mean by biopsy is that somehow or another you have to get a piece of tissue and send it to the pathologist. They have to look at it under the microscope, see what you're dealing with. And biopsy could be something that you do with a needle. You get a very tiny amount of tissue, and for things deep inside the body, that's the usual way that we do it because it tends to be safer. When you start using bigger needles, you can run into more complications. You worry more about bleeding type of problems when you do these biopsies. But nonetheless, you want to try to get some sort of piece of tissue for the pathologist to look at to give you an answer. But for this type of problem, you don't always need a biopsy. Biopsy is required if you have a tumor that you don't think you're going to be able to get out of the pancreas. In other words, there's no way you're going to be able to operate on this patient to get rid of this thing. And I'll talk a little bit more about it later, but in general, when you're dealing with pancreatic cancers or something that may be a pancreatic cancer, the preferred management is always surgery. If you can get it out, that's always the best way to approach it. However, if it looks like you're not going to get it out, basically you have to somehow establish that you have pancreatic cancer before the patient's going to be eligible for any other treatment like chemotherapy or radiation. However, if you have a type of tumor in the pancreas, like the CAT scans I was showing you of that patient with that very large mass, the patient did have a biopsy, but it didn't really show anything. It was just an inadequate specimen. But you knew from the beginning that that thing could not stay there. That was like too big a mass, and it was just going to, even if it was benign, it was going to cause problems. You don't worry about rebiopsying it and trying to establish a clear diagnosis. You're going to just take that out. And plus, there's some other complications you can see with a biopsy that you worry about. You start sticking needles in these things, you can end up with spread of cancer. And the other thing is, even if you get a negative biopsy, it doesn't necessarily mean it's not a cancer, because the needle biopsies tend to be very small bits of tissue, and sometimes you just don't get a good enough specimen to clearly establish a diagnosis. There's no substitute for having the whole tumor mass taken out and having the pathologist look at it. And the other thing is, even when you have a tumor mass, it's not necessarily all solid cancer. You'll have parts of it that may be relatively benign and parts of it that are cancerous, and you can't always tell that looking at a CAT scan image or an ERCP image. So we don't always need biopsy, but we do prefer having a biopsy. This is just some information about the pathology of pancreatic cancers. Not all pancreatic cancers are the same. We often will use words you'll see on the slide here like neoplasm. Neoplasm just means that you have an abnormal growth. It doesn't necessarily have to be a cancer. There are benign growths that will occur in the pancreas, and basically we call them benign neoplasms. It just means an abnormal growth, but it's not a cancer. And then there's cancers. Cancers are a type of neoplasm. They're malignant neoplasms. But ductal adenocarcinoma is easily the most common type of pancreatic cancer. And basically what this means is that it's arising from the ducts in the pancreas. That's shown on those diagrams, how you have those ducts in the pancreas. And it's not just that main duct that's running down the middle of the pancreas, but there's all these little side branches too that will also carry the enzymes. But anywhere along the lining of the ducts is the most common place where the pancreatic cancers will arise. And so the pathologist will see that when they look at the slides, and they'll say, yeah, you have a ductal carcinoma, and that's like 80–90% of all pancreatic tumors. And then there's other types of things that you'll see, like we'll see what we call pancreatic neuroendocrine tumors. That's what Steve Jobs had. And, these tend to have a somewhat slower course, but they can, in the long run, be just as nasty as the regular pancreatic cancers that tend to get a lot of press, because you hear so many people getting it. Like Pavarotti had pancreatic cancer, Patrick Swayze, and you hear about a lot of these people having pancreatic cancers. They basically have the ductal adenocarcinomas, and those are very nasty. They move very quickly, and that's why you see so many cancer deaths, as I was showing you on the first couple slides. The pancreatic neuroendocrine tumors will tend to have a somewhat slower sort of growth, but and you have a higher cure rate with them, but invariably, if it's nasty, it's going to kill the patient. And there's other more minor types of cancers and other tumors that you'll see that I really didn't want to get into too much. Basically, the management of pancreatic cancer, we tend to think, once you have a diagnosis, we tend to think along the lines of the fairly standard treatment modalities that we have for just about all cancers. Basically, you think in terms of surgery, chemotherapy, radiation, and typically, like most cancers, it tends to be some combination of treatment. The preferred management for pancreatic cancers, if you can get it out, you want to do surgery. And getting it out means that it hasn't spread anywhere. It's not into those blood vessels that I was talking about. However, even in cases where we do get it out, it still has a very high chance of coming back. Like I said, it's a nasty cancer, and so you're still concerned about cancer cells somewhere else in that patient's body or somewhere else in the area of the abdomen. And so those patients, even after you've had a successful surgery, you still will think along the lines of giving them chemotherapy or radiation afterward, because you're worried that there's other cancer cells in there that you just haven't picked up, and you're trying destroy them now when they're still microscopic. In patients that you can't do surgery, your only option may be chemotherapy and radiation. And so, those patients will often get somewhat different types of chemotherapy and radiation management, but surgery is not an option, so that will typically be their only choice. This just shows you what percentage of pancreatic cancers are considered quote-unquote resectable at presentation, meaning that you look at your imaging, you look at all your tests, and you say, you know what, I think we can get this out. We're going to go do a major operation. And you can see it's a pretty low percentage for cancers that come in the pancreatic head. Maybe 10–15% of them you're going to be able to get out. That means 85–90%. By the time you've diagnosed them, the patient comes in and you figure out that you got a pancreatic cancer, it's already too far gone. You're not going to be able to do anything surgically. Pancreatic body and tail tends to be a little bit worse. And the reason is because the pancreatic body and tail is in sort of a deeper part of the abdomen, and it also doesn't cause bile duct blockage. We were talking about how the pancreatic head cancers will cause that bile duct blockage, and the patients will have jaundice. Well, that jaundice will tend to come in earlier, those type of patients. And so you will pick up a few more of those patients than you would in the body and tail. Body and tail cancers, I mean, they can get the size of like softballs, and they've already spread everywhere by the time the patient shows up. And as we discussed, those patients have very vague symptoms, so there's really no good early warning signs for that. This just shows what I talked about before, what's considered unresectable pancreatic cancer based on preoperative testing. And basically, if any of the images you do CAT scans, MRIs, I didn't put it on our list, but patients often will get PET scans. If you see any evidence of metastasis, in other words, spread of cancer away from the pancreas, they're not resectable. So you're not going to consider surgery to go in there to do anything about it. And as we discussed before, I didn't tell you the names of all these arteries. Again, I'm not going to quiz you on this stuff, but we have what they call the superior mesenteric artery, celiac artery. You also have these veins. If there's significant involvement of the veins, you may not be able to get it out. Another important thing is if a patient has significant medical comorbidities. If you think back, I don't know how much of the stuff you're going to remember, but back on one of the earlier slides, I pointed out that 80% of all pancreatic cancers present between ages of 60 and 80. Well, when you get patients that age, they tend to have a lot of medical problems. And if you have patients had like 2 heart attacks, and they have a bad heart, they were a smoker, and they have emphysema, that patient is not going to get through any major surgery. And so all that has to be factored into any decisions you make in terms of how you're going to manage them. So there's a lot of thinking that goes into this, and typically the way we manage the patients here at Cooper, with our affiliation with MD Anderson, most of these things involve some sort of multidisciplinary planning. In other words, we talk to the medical oncologist, the radiation oncologist, you talk to the primary doctor of the patient, the cardiologist, and you basically make a determination of how best to manage this patient. But there's a lot that goes into that. But typically the imaging is significant, as I point out here, because if the cancer is spread, you don't have too many choices. Now, the curative surgeries that we do, I'm not going to show you any like gory slides or anything like that. I know some people like to see that sort of stuff, but you can find them on YouTube if you really want to see them. The name that people most commonly know is this Whipple procedure. We actually call it a Whipple pancreaticoduodenectomy, but I guess that's why people just call it a Whipple, because they don't want to say pancreaticoduodenectomy. And there's variations of it. You can do it with and without taking out the whole stomach, or part of the stomach, I should say. Dr. Whipple described the procedure in 1934, but he was not the first one to do it. There was another guy who did it back in 1909. But Dr. Whipple sort of gave it a good scientific footing, and I guess the world was ready for the procedure at that point. A lot of aspects of surgery and anesthesia had caught up that we were able to do the procedure, because it's a surgery that has a lot of risk involved with it. But he did something like 35 of these Whipple operations in his day. The other operation we do is what we call a distal pancreatectomy, which is removing the body and tail of the pancreas if the cancer is in that area. And that's usually done with a splenectomy, and you'll see on a later slide why that occurs that way. But that's for cancers that are in the body and tail part of the pancreas, not the head part. The Whipple is specifically for the pancreatic head cancers. And occasionally a patient may need what we call a total pancreatectomy. We actually remove the whole pancreas, but I can tell you I've done like 100 Whipples and probably like 150 distal pancreatectomies. I've never done a total pancreatectomy because usually if the cancer is that big that's involving the whole pancreas, it's already spread and you're not going to get that thing out. So it's pretty rare that a patient will present that they're going to have any benefit from doing a total pancreatectomy. And this just shows a picture of Dr. Whipple. This is from the cover of a book. Basically, you can buy this book, Memoirs of Alan Oldfather Whipple, on Amazon. I did not read the book, but apparently he had an interesting life. He was born in Persia. I think his parents were missionaries. He ended up doing his undergraduate studies at Princeton here in New Jersey, and eventually after he trained as a surgeon, he worked at Columbia Hospital up in New York. That was where he did the bulk of his professional career, and when he retired, he was back down here. He was like on board of trustees or whatever at Princeton, and he eventually died in Princeton, and he's supposedly buried up there somewhere. But that was Dr. Whipple. I don't think anybody's bought like the movie rights to this book or anything like that. I don't know how good a book it would be. I don't know, maybe like on that Lifetime channel they would show something like that. And so this is basically that original anatomy picture that I was showing you at the beginning, but it just shows you where the cuts would be for a Whipple. You'll see on the couple slides after this you get a better idea, but the standard Whipple is basically you're going to remove about 1/3 of the stomach. You have to actually cut out this bile duct here. You have to cut this jejunum, this piece of intestine down there, and you're basically cutting off the pancreatic head here. And, basically you're going to remove this area right here because this is where the tumor is going to be. So it's a big operation to do this. There's also a term that's fairly popular. People call the operation what they call a mini Whipple. A mini Whipple means that basically you're saving this part of the stomach. So instead of cutting across the stomach here, you're cutting there. And you can do that if you have a smaller tumor. So you're actually saving the whole stomach. Now, is there any clear advantage to that? I don't think there's any clear statistics that show that there's a clear advantage to doing that, but people will still do it. But the operation still ends up being a big operation doing it. And let's see.
Is there a difference to the patient in terms of having that much of the stomach removed?
In general, they have just as many problems either way. The question was whether it makes a difference to the patient. Patients often like to think they want to keep as many of their parts as possible, and so they want to keep their stomach as much as possible. But typically when I'm talking to patients, I also have to sort of explain to them that you also want to get rid of the cancer. There are times when the cancer is just so big, you can't do that. Like, if it's involving tissues that are very close to that part of the stomach, the safest thing is to take out that part of the stomach to make sure you get it all out. But nobody's shown any clear advantage or disadvantage of doing it in general one way or the other. And this just shows what happens after removing a mini Whipple specimen. You can see here the bile duct is cut. Here's the other cut end over here as part of the specimen. You can see we have the whole stomach here that's preserved, and we sort of cut across this first part of the duodenum here. Here's the cut end there. Here's the tumor in the pancreas. Here's the other cut end of the intestine, and here's the part of the intestine that's still inside. And you can see the cut end of the pancreas. Here's the pancreatic head, and here's the body and tail still in there. Now, be very careful. I'm like showing you these diagrams, and they're like, I try to pick the simplest diagrams, but I don't want people to think that they can go home and try to do this themselves. Some people like go home and they want to look at a YouTube video and say, what, I'll do that, or we'll try to save some money. This should only be done by professionals. And this just shows a common type of reconstruction. You can see here in the left lower corner here is this smaller version of the slide that I showed before where we removed the specimen for the mini Whipple. But this shows a reconstruction for a Whipple. You can see here the patient had a large part of the stomach removed, but a large part of it is still in there. Here's where the bile duct was cut, just like you see over here. I'm sorry I'm not moving this mouse very smoothly. And here's where the pancreas was cut. Right here you see it sitting behind the stomach in this left lower corner. And you can see what we do is we bring this piece of intestine here, and you bring it up to here, and we actually sew it to the pancreas. That way, whatever enzymes this piece of pancreas make will still get into this piece of intestine. The bile from the liver will come down here, will get into this piece of intestine. It goes into this piece of intestine here, and here it's basically sutured to the stomach, and so any food that the patient eats will come down here, come down to the intestine, mixes with all the bile and the pancreatic juices, and then it goes through the rest of the GI tract and eventually comes out the other end. And so the patients can survive very well this way. Now, obviously their eating isn't totally normal, like it wasn't what God gave you when you were born, but the patients in general will do very well. Now, it's not the simplest surgery to recover from. I mean, these surgeries, if you do it really fast, you may do one in like 3.5, 4 hours in a patient with good anatomy, but they can easily last 5, 6, 7 hours in patients who have tougher anatomy or more difficult tumors to get out. And typical recovery in the hospital, usually the fastest you get a patient out will be around 7, 8 days. The patient does well. More typical, you're looking at 10, 12 days. If a patient has any problems, the procedure will have complications associated with it. Patients can easily be in the hospital for 2, 3 weeks before they get out of there. And it has a long recovery. And if you're doing this operation for cancer, I should point out that it's not always done for cancer, but if you're doing it for cancer, even after they recover from the surgery, now you're typically looking at chemotherapy, radiation on top of everything. So the patients get beat up pretty good when you go through this whole process of trying to treat a pancreatic cancer. Now, this just looks at what we call the distal pancreatectomy and splenectomy. This is taking out the body and tail. So if a patient had a tumor in this body and tail part of the pancreas, now this particular image shows the body and tail where we sort of turned it up, like we've already loosened it up from the back of the abdomen and we sort of flipped it up. Now, the things that you didn't see on the previous anatomy slides was that the spleen, that's what this thing is here. I know I didn't label it that well, but this is actually the spleen. The spleen sits right at, see, most of these pictures were from like professional publications, not for the lay audience, but the spleen sits right up against the tail of the pancreas here. And the blood vessels that go to the spleen, they travel right behind the pancreas. And that's what you're seeing right here, where these little lines are drawn. There's a splenic artery and a splenic vein. And so if you have a tumor that's in this part of the pancreas, it's typically going to be impinging on or involving those blood vessels. And so when you're taking out a tumor in the body and tail of the pancreas, those blood vessels are going to go, because you're basically trying to remove the whole tumor. But once those blood vessels go, and generally your spleen's going to go. So that's why the spleen almost always goes when you take out the pancreas. But people live fine without a spleen. I don't know how much you know about spleens, but spleens are commonly injured when patients have blunt abdominal trauma, like in car accidents. You hear people have internal bleeding and you have to have surgery. The most common thing that's bleeding is the spleen. Second most common thing is the liver. Although nowadays, for abdominal trauma, they do try to save the spleen if they can. You can't always save it, but when you're dealing with cancer surgery, in general, you'll find that you won't be able to save the spleen. But patients can live without a spleen. Their immune system may not be functioning quite as normal, but it still functions 99% of normal. And so they tend to do fine. Now, talk a little bit about laparoscopy. Most pancreatic surgery is done through the standard open abdomen. I mean, when we make these big old cuts like Dr. Whipple would have done back in 1935. However, laparoscopy is a major force, and there's more and more capabilities that we have developed with laparoscopy. Laparoscopy basically is like the little punctures we make nowadays, like when we take out gallbladders, we'll take out appendixes. There's all sorts of things we'll do with laparoscopy. We do laparoscopic colon surgery, patients who have colon cancers. The pancreas also sees a fair amount of laparoscopy. One way we can use laparoscopy is in a patient who you think may have a cancer. You can go out, but when you're starting the surgery, you're worried that there may be cancer spread elsewhere in the body that is not showing up on any of the CAT scans or MRI imaging. And so if we put a scope in the patient, we look around the abdomen, sometimes you'll see tiny little spots where cancer is spread. And if it's spread, you just sort of back out, after you've only made these tiny little punctures. You don't have to make a big old scar on the patient just to see that it's spread. But if it's spread, there's no point in doing one of these Whipple operations or distal pancreatectomies. So it saves a patient who often is elderly, the the potential risks of having a big operation. For laparoscopic distal pancreatectomies, that means taking out the body and tail with the spleen. It's fairly routine nowadays, especially with the smaller cancers. We just put the scope in there and we can take them out fairly easily, although usually you're going to have some sort of a bigger incision at some point because you got to remove the specimen. You like to get the specimen out intact, so it's not all tiny little punctures, and generally you'll need at least a small incision that's going to be roughly big enough to get a hand in there, and because the specimens will have a certain amount of size and you want to get them out intact. For a Whipple procedure, that's a lot more difficult thing laparoscopically, but there are people who've done it, and I don't know that we've hit 1,000 around the world, but there's been several hundred of these things done. The most prominent person that I hear about is a guy in Paris who does these things. But again, it's very select patients. You can't have these big giant pancreatic tumors that you're going to be able to get out that way. I mean, you just don't have enough elbow room maneuvering around laparoscopically to get stuff like that out. And just a brief word about robotic technology. We do have these robotic devices that allow us to do a lot of laparoscopic surgery with a lot more skill than we could do with the standard laparoscopic instruments, and people have been using it for Whipples, and I expect that that will have some sort of impact as the robotic technology improves. Just a couple words about complication rates. Like I said, it's a big operation. The mortality rates run roughly around 4%. Now, that's far lower than what you were talking about back in Dr. Whipple's time. In fact, even back when I was a medical student, I'm talking like in the late 70s. In the textbooks, you would see that you shouldn't do Whipple procedures on anybody older than 65 because they thought it was too risky an operation. 10% of the patients died from the operation. I mean, now all the time we see patients who are 75, 78, 82, all these older patients, and their medical conditions are better controlled. We have a lot of other techniques. It's not just the surgery, but the anesthesia, the care after the surgery. We have a lot of good intensive care stuff. We can pick up complications a lot quicker. We have better antibiotics. We have so many things that we do better that the patients get through the operation. So in general, the risk is a lot lower, but it's not 0%. Most places that do a lot of them, typically it's going to run around 2%, the mortality rate. And this just lists some of the other complications you can see. Like all those places I was showing you on the slide of how we reconstruct after Whipple, where we sew the bile duct and the pancreas and the intestine and the stomach. All those places can leak. You can see infections. There's a whole host of problems that you can see. This shows some basic survival statistics. If you look at Whipple operations, what we call the 5-year survival, this is basically a cancer statistic. The other survival I showed you on the previous slide was the survival from the surgery. But if you look at cancer survival, you'll see in 5 years they don't do too well. It's only 10–20%. These are patients that you think you've successfully resected, and most of these have also gotten chemotherapy, radiation, still get a lot of cancers that come back. Distal pancreatectomy, no better. 10–20% of them make it 5 years. That's about it. If you look at overall pancreatic cancer survival, that means that all 46,000 of these patients that are diagnosed in the United States in 2014, we expect that only 5% of them are going to survive 5 years. So that includes all the patients who have surgery, the patients who don't have surgery, just have chemotherapy, radiation, or even no management, because it may be so far gone. Only 5% of it make them 5 years. Now, we may come up with something new in 5 years, and so that may turn around very quickly. But the unfortunate thing is, despite all the progress that's been made with a lot of other cancers that you hear about, with like breast cancer, colon cancers, we have all sorts of better screening techniques, so we find these things earlier, and we have all sorts of better management. None of that has been applicable to pancreatic cancer. We've been staring at this 5% number for like the last 20–30 years, and things just haven't changed much. If you look at a patient who comes in with locally advanced cancer, generally they only make it like 8 to 12 months. If they come in with metastatic cancer, typical survival is only going to be 3–6 months. So that's why when people see the diagnosis, people don't look at it very favorably. Also, I was going to talk a little about some of the obstructive problems. I talked about the obstruction on one of the earlier slides, how it causes a blockage when you have a pancreatic head cancer, you get blockages in the bile duct, you get blockages of the pancreatic duct, you get blockages of the duodenum. We have ways of bypassing that. Like I said, if you can get the cancer out, that's the preferred way to management. But if you can't get it out and the patient has a blockage, you want to relieve the blockage. You don't want to leave a patient jaundiced. Being jaundiced is terrible because the patients actually get very itchy. You can't stop the itching. They scratch themselves crazy. Nowadays, we have pretty good ways of resolving those blockages with the bile duct obstructions, the duodenal obstruction. We put these stents in. And this just shows an example of a plastic stent through a bile duct blockage here. You can see this is the ERCP scope in the patient. Again, you see the spine. You can see some of the contrast in a bile duct here. But this patient ended up with a stent. It's basically like a straw is what it is, like a little plastic straw that they shove up there. And that way the bile can flow through this straw down into the intestine. And basically the patient gets relief of jaundice. It's a very effective technique. Another thing that we use sometimes is what we call a metal stent. Basically, when you look at the metal on the X-ray, it sort of looks almost like those Chinese finger trap type of configuration. But on this image, like you can see this very faint outline where it's darker here. That's gas in the dilated bile duct, and basically the GI doctor has shoved this stent up there where it's dilated because the tumor is down over here. He shoved the stent right through the tumor, and that way the bile can flow through this stent and the patient's obstruction is relieved. And so they gradually get rid of their jaundice so they're more comfortable, and they haven't had a major operation. Now, it used to be that we had to do major operations on all these patients to relieve these obstructions, but now it's pretty unusual that we have to do a major operation. And this just sort of looks at some of the non-surgical treatments. We talk about chemotherapy regimens, which are basically based on these two main chemotherapy drugs, the 5-FU gemcitabine, radiation therapy. Most commonly we use some sort of combination of chemotherapy and radiation. And these treatments can be applied either along with surgery, and there are times where we would actually give chemotherapy radiation before surgery to try to shrink a tumor before we get it out. But more commonly we use it after surgery. Or if you have a patient that you can't get the tumor out, you basically only have chemotherapy or radiation as your management option. Some of the newer drugs, this bevacizumab, Avastin, it's been a groundbreaking drug for management of things like colon cancer, but doesn't seem to help at all in pancreatic cancer. Nobody has a clear explanation why, but they're always coming up with these new drugs, and so people are still hard at work trying to come up with new stuff for pancreatic cancer. People have been working on vaccines for years, but again, this is still considered experimental. You'll once in a while hear of a promising study, but none of this has reached into what you would call a standard type of use format. So key points. Pancreas cancer continues to have a relatively poor prognosis. Overall, 5% 5-year survival. Only 10–15% of the patients are candidates for surgical resection, which is our best management modality. Pancreatic cancers can be performed a lot more safely than in the past, mainly not just because of surgery, but because of all the other improvements of medical care of the patients. And basically, we need to identify better methods of early detection, and we have to improve our non-surgical management of these patients. So that's basically the end for my talk, and I think we're ready for our next speaker here.